Internal Medicine Associate, and I'm very excited to welcome all of you here. I recognize many of your faces, either because you're my own patients or you are patients of my beloved colleagues here in the Internal Medicine Associates. So thank you so much for joining us at 1 o'clock on a Tuesday on a beautiful, beautiful summer afternoon. And I will turn it over to Susan Edgman Levitan.
Hi, good afternoon. Thank you, Dr. Leeds. My name is Susan Edgman Levitan, and I'm the director of the Stoeckel Center for Primary Care Innovation in the Division of General Internal Medicine. And it's my pleasure also to welcome you to our IMA Team 2 Town Hall today. Before we get started, I want to go over just a few housekeeping rules. All of you are muted to eliminate any background noise, and you'll remain muted throughout the entire town hall. You can view the speaker on your full screen. If you go up to the top right-hand corner of the Zoom, you'll see Speaker View, and if you click on that, you'll be looking at the speaker throughout the presentations. And then if you want to switch and look at everyone else, you go to Gallery View. We ask you, if your picture becomes jumpy or out of sync, to turn your video off, because sometimes we have so many people on the calls that affects the wireless connections. And if you turn your video off, you'll still be able to hear and see the speaker, but it will make the video connection stronger. If you have questions during the town hall, please use the chat function, and the chat box is right in the middle at the bottom of your screen. And if you chat to everyone, we will see your questions. And when we get to the end of the formal presentations, we'll start taking questions, and I will field them to the different presenters on the call today. One thing that we ask is, because everyone can see anything that's written in the chat function, and we can also see you on the screen, please do not ask any personal medical questions in the chat, and don't show us your rash or anything else, because you'll be sharing it with everyone. So please keep that to yourself. But if you do have an important medical question or any medical question, please reach out to your doctor or the other people on your care team. And we'll try to get through all the questions as quickly as possible. So we have a wonderful group of expert speakers today, and I'm going to introduce all of them, and then we'll get started, and they will just hand the speaking off to each person as we go through. So our first speaker is going to be Miss Maya Gens, who is the head nurse practitioner in the IMA. She's going to be talking about how we're making the practice safe. We're then going to hear from Dr. Michael Beer, who's a physician on IMA Team 2, and he's going to share with us sort of the latest about what we know about COVID-19 testing and immunity. Then we're going to hear from Dr. Michelle Leroux, who is the clinical director for the Division of General Internal Medicine and also a Team 2 physician. And she's going to be talking about when it's important to come in for care, when you can get your care via telehealth, and how to do a virtual visit, how to prepare for that. Next, we'll hear from Dr. Juliet Jacobson, who is a palliative care doctor and the medical director for the Continuum Project. She's going to talk about what matters most and things you might want to think about in case you do need to be in the hospital. And then we're going to have a brief overview of the Ageless Grace exercise program from Miss Nori Mazzone, and then we'll close with questions and answers. So with that, I'm going to hand this off to Miss Gens.
Hi, and good afternoon, everybody. It's nice to be with all of you. I will keep my part very short because there's a lot to cover, but I just want to let you know what the overall process is for patients coming into our hospital, and how we have tried to cover all the bases to make it a safe, efficient, and helpful visit. So the screening process, as some of you may know, starts way before you enter the hospital. So when you call to make an appointment, you have to be screened for COVID symptoms. And then if you screen negative, meaning that you're no symptoms, and you can be given an in-person appointment, and then you get screened again a couple of days before your appointment, and then of course you get screened again the day that you check in for your appointment. So there's 3 different times that a patient gets screened to ensure that other patients and staff are kept safe, and that the patient, you know, him or herself is not at risk for COVID. So we have set up the practice so that we have our staff, all of our staff are wearing masks. We have a very robust cleaning process to ensure that all of our surfaces are being cleaned on a very regular basis. We're limiting the number of people in the practice at any given time, including staff and patients, so that you'll always be able to keep the 6 feet of distance between yourself and another patient in the waiting room. And that we're trying to reduce any type of line for checking in or checking out. The staff all have the correct PPE on and are practicing very intensive hand hygiene. And, you know, and then we are making sure that patients are being seen in the correct area. So, you know, if we have patients who we're worried about, we immediately transport them to an area where we can sort of isolate them. That has not come up very often because of our rigorous screening process beforehand. So I don't want to be too short, but I just wanted to give people a sense of all the precautions that we're taking, and let you know that I feel like the IMA has done a great job in terms of following all the direction from infection control and the CDC around regulations in terms of keeping our practice safe for our staff and our patients. And if you ever have any questions about it or any concerns, I'm always available to speak with directly. So I'll leave it at that. But we hope to see you either virtually or in person. And thank you very much for joining us today. We miss all of you.
Is it my turn?
Yes, it is.
So I'm Michael Beerer. I'm one of the docs in this practice. Been here a while, and I'll take the opportunity to get the big message to you first, because you know attention might be short. I just wanted to thank you as our patients on behalf of all of us providers. I think it's been really quite gratifying to hear from you the kinds of messages of support for us and the care that you patients are sending toward us providers. And it's, you know, it has been stressful at times, and just your well wishes kind of emphasize how we're all in this pandemic together, and more broadly, we are all in this world together. We are, you know, our mortality and our humanity binds us together. So I hope you guys are feeling it the way we're feeling it, and I just want to express gratitude as a provider to you. And no matter what else, this is stressful. This is a stressful time. I have a sense that you are able to you are unusual in that you're able to take an hour in the middle of a weekday to get online, to use a computer or whatever you're using to connect with us. So that that already tells me that you're doing pretty well relative to lots of our patients. However, it is stressful. It is, and I think we need to just all as a group kind of you know, take a breath, remember what normal life was like, and get used to this new normal that we are creating and that we have to work with for some time. So that's sort of the kind of editorial comment. I will ask you as a favor to yourselves and to us to do a few things. One is to take care of yourselves, be kind to yourselves, eat well, sleep if you can, get some exercise, don't drink too much, don't use other substances too much, because by taking care of yourself, you're helping us to take care of everybody. So it is not selfish. It's good for everyone. You've already probably learned about how to get onto video, help your friends get onto video, because this is going to be something we're going to be doing in the future, and we'll rely on it. I hope you will be able to benefit from it. And you're going to hear from Dr. Lheureux about how to come in, how not to delay getting care. Don't delay getting care. Don't put off routine care. That will also help us to take care of you better. So, getting to the details, it's now August 11th. Last week, the governor ceased the rollout of phase 3. He delayed indefinitely the second phase of phase 3. He reduced the maximum number of, the allowable number of people in outdoors gatherings from 50 to 25, and he put some teeth behind the enforcement of the rules for preventing COVID-19, for maintaining social distance, and for taking precautions. Why is this? The rates of positive tests ceased to decline. So if we're testing and we're getting very few positives, that's a good indicator that the prevalence of infection is low in the community. It had been falling very nicely to the 1% range or so. And in recent weeks, it was up in the 2% range. That may sound like not much, but it's a kind of nearly a doubling. Hopefully that's going to attenuate and stabilize. But I think we need to be very vigilant about monitoring cases and preventing infection. The good news at MGH is that our census of COVID patients is very low. As of last week, there were 14 inpatients with COVID-19 diagnosed, only one ICU patient. Only one ICU patient. It's extraordinarily, it's a much better scene than we had a couple of months ago. We are continuing to use our respiratory illness clinic, which is a way of evaluating patients who have minor symptoms associated with, possibly associated with COVID. We also have another facility where we can do routine medical care for patients who are higher risk for COVID or have tested positive for COVID, the RAC. And those, I think, we'll be keeping those facilities in place and using those methods going forward. As of last week, we had 1,600 patients, give or take, discharged from MGH with COVID. Unfortunately, there were 192 patients at MGH who succumbed to COVID. The employee testing rate is relatively stable and feels fairly high to me, 10%. Correct me if that's wrong, but it's a more of a statement that we are selectively testing even our own, and we're not over testing, we're not profligate in our testing of our colleagues. COVID is fairly easily transmitted by the SARS-CoV-2 virus in droplets. It is also probably aerosolized. The incubation period is about 4 to 5 days on average. That, I think, is the median. 97% of patients will develop symptoms by 11.5 days. We are very confident that 14 days without symptoms is a good period to wait to see whether or not infection takes hold. That's the basis of this 14-day quarantine period. People can transmit while they're asymptomatic. People transmit when they're asymptomatic. That is a huge reservoir of potential vectors of the virus. There are as many as 80% of people asymptomatic. Well, 50 to 60% have been documented in certain populations when testing was routine. For instance, in some nursing homes or other facilities. So there's a very high seropositivity, not seropositivity, but positive virus rate of people without symptoms. These are people who can infect. Now, conversely, after infection, when people recover, takes a couple of weeks to recover, they may still be shedding virus, but they may not be infective, even though they're shedding virus. So it's very complicated. People develop immunity, may still have virus that's detectable, and may not be infective or might. So it's there is a lot of developing information on this. The spectrum of illness, given all people who get infected, probably 80% have mild illness, or no illness. 80% won't come to the hospital, won't really need much by way of care other than supportive care, fluids, aspirin. It's like treating a bad cold at home. 15-ish%, 14% have more severe illness, meaning they'll have a decrease in their ability to oxygenate their blood, or they'll have a positive chest x-ray showing an infiltrate. And 5% become critically ill. They'll be in an ICU, either intubated, getting ventilatory support with machines, or otherwise sick. And then 1 to 2.5% will succumb to the illness. So it's no laughing matter. If you have to have a pandemic, you shouldn't choose a virus with a title of severe acute respiratory distress. The severe is real. So we need to remain vigilant and get tested appropriately. PCR testing is testing of the RNA of the virus, and it performs pretty well, but there may be a fairly significant false negative rate. So you may miss cases with the PCR testing. That's why we tried to focus testing on people who have a reason for testing. A lot of people want to be tested just to know, just for, it's like, there are people who want to get total body MRIs just to know, but we don't do that because the performance of tests are such that even good tests will not be diagnostic in the setting where the likelihood is really low of a disease being present. So that's why we ask about symptoms, we ask about exposures to people who are documented to have been COVID positive, and what's an exposure to someone who is known positive. It's 10 minutes of face-to-face contact, less than 6 feet apart, without masks. So if you've been in that kind of contact with someone who has subsequently tested positive, then you have a real exposure, and you need to either quarantine for 14 days, because that's the time period where people will develop symptoms, or get tested and quarantine for several days after the test comes back negative. But that's our definition of a real exposure. I don't know if we want to get into too much more detail. I don't know how much time we have to share among other speakers. So
we need Dr. Beer, we need to wrap up to move
okay.
on so we have time.
So then I'll just stop and say I'll stick around to the end of the hour and be happy to answer questions.
I'm sure you're going to get some questions. So let's move on to Dr. LaRue.
Hi, everyone. Nice to see you all. I'm Michelle LaRue. I'm an internist, a PCP, and the Director of Primary Care here at MGH. And I've been asked to speak to you around the importance of getting care, which we've learned in this pandemic, but also in prior, that it's understandable that people are hesitant to return to the hospital or to get the necessary care you may need in your doctor's office because you're concerned about getting whatever is there. So of course now we're talking about COVID. I want to assure you that MGH, as part of the Mass General Brigham system, but MGH in particular, is being very, very vigilant about ensuring our patients, our visitors, and our staff are safe. You know, I don't want to reiterate what Maya Gins said, but I would like to highlight a few additional points. You know, beyond screening patients, which we do multiple times before they arrive, whether to an admission, an elective admission to the hospital, or even to a doctor's office visit, we also screen all employees every day. It doesn't matter if you're a physician, you're a medical assistant, you're the secretary or the nurse, we all have to attest to our health every day. And if we screen positive on any of that, we are not allowed to work until we are cleared by occupational health. That is a way to keep our patients, our other staff members safe, and our visitors. The visitor policy is another particular thing I want to make sure you understand. So any visitor coming into the hospital to see an inpatient or to possibly accompany someone on an outpatient visit has some strict policies. For the inpatient side, it's the same travel policy that exists throughout all of Massachusetts. If you are not an essential visitor, meaning you're not deemed necessary to be there because you're a support person or a caregiver, if you've traveled and you cannot say you've quarantined for 14 days and are not negative on a test, you cannot visit. There are no visitors in the outpatient arena unless you are an essential visitor, meaning you need to be there because you may have a child and you're the parent, or you may be the caregiver to someone that's suffering dementia. But again, we're very, very vigilant at the door of screening all visitors. So I want you to understand that because it's not just patients being screened, it is the employees and the visitors as well. Another important piece is the environment. I saw some questions around the elevators. I mean, I can attest that from day one of this COVID pandemic, I've been working with infection control in the outpatient arena to set up these respiratory illness clinics to make sure our outpatient environment and our hospital environment are extremely safe. Everything is marked 6 feet apart. Everyone has to wear a hospital-approved mask. Though you may like your own, don't take offense. We will ask you to remove it when you come into the building because ours are infection control approved. And we will ask that the reason visitors aren't allowed in certain situations is not that we don't want you there to care for your family member or be present, but we need to decrease what we call the density of people. That impacts COVID's transmission, to what Dr. Beer was saying. So we're doing that really to keep everyone safe. So I want to stress that getting care now is very important. But with all of that, we've made the environment safe. But let's say you're not comfortable coming in, or let's say you may have a symptom that precludes you from coming in, or you just don't feel safe doing so. We have different ways of delivering care now. We can do it obviously in person. As we've said, we've made it very, very regimented, but in purposefully so, very safe that way. But we also can do telemedicine and virtual medicine or telemedicine. I think is truly the silver lining of the pandemic, if there's such a thing. You know, we have talked about it since I've been a physician, and that was in the late 90s, and it moved at a snail's pace, and it moved at a snail's pace last year. Well, all you take is a good pandemic and everything moves quickly. So now we have virtual care that is just part of everyday medicine. And you can get a virtual visit, which I'll describe a bit more in a minute, when you need it, if it's the appropriate care to get. And I want to stress that appropriate care is important. So you can imagine that having virtual care for something like diabetes, to have your blood sugar check discussion with your physician, or high blood pressure, or depression. There are a lot of conditions that virtual care is appropriate, but there are times when it's not. I mean, if someone has abdominal pain and requires an exam, that again is not a time that it's appropriate. But it can be used and is actually the appropriate care in many situations. It's convenient, it's from your home. You know, you don't have to come into the hospital and potentially risk out in public the exposure. I'd say it's very minimal here, but out in public, their potential exposure. And it can be actually very intimate with you and your physician or nurse practitioner or physician's assistant whom you're seeing. I find with my patients, it has been a wonderful way of communicating because I get to see their environment. I get to see sometimes their family members in the background, or they'll bring them in. So I think there's really many plus sides, and they're more comfortable in the virtual environment sometimes because they're in their own setting. You can do it very easily with a phone. I do not want anyone to think that you have to be tech savvy and have to have a computer set up to do it. We can do virtual care by the phone. I think as physicians, we'd love to have the option to do it virtually and see you, because we can tell a lot just by seeing your face and you can see ours. And that's done through our online patient portal, the patient gateway. You can sign up, and we use this thing called Zoom, which now is common lingo. So with Zoom, you can do a virtual visit on your desktop at home, on your iPad at home, on your mobile device. There's many ways of doing it. I would ask, if you do that, to kind of test it out a little bit and make sure you know how to get on. And our secretaries are very good about giving instructions. I would recommend you write some questions or things you want to cover during the visit, just like you would for a regular visit. Make sure your medications are in line with what we may ask you about, because we'll run your medicine list. If you can check your vital signs, if you have a blood pressure cuff, if you check your blood sugars at home, all of that information will be very helpful to have at the time of the visit. So I'm sure there'll be more questions afterwards. I want to turn it over to Dr. Jacobson, but I'm happy to answer any that may come up. So all yours, Dr. Jacobson.
Thank you, Michelle. Hi, everyone. I'm Juliet Jacobson. I'm one of the palliative care clinicians here at Mass General, and I work in the inpatient setting and also in the clinic. And part of my job is to train other clinicians in what we call matters most conversations, which are these conversations about your goals, your values, your priorities that we have with all patients, so that we understand how to help guide medical care. And during the pandemic, my job was to go down into the emergency room and have these conversations with patients who were very sick. And what I would do is I'd put on my PPE, my mask and my goggles and my gloves, and I bring my cell phone and I dial the patient's family on my cell phone. I used video so I could see people, and I'd go into the room with patients and we'd talk about what their priorities were for their healthcare if they did get sicker. And one of the things we learned from these conversations, and it's not surprising, is that it's really hard to think about the what ifs when you're sick in the emergency room. First, you're sick, you're not feeling well, and then your family, even if I had them on video, they're not there with you to hear the conversation and to think together about what to do. And so now that we have this pause, we'll call it a pause, now that we have this pause in the pandemic, we wanted to reach out to people in a different way to help people think about these conversations and to reflect a little bit more for themselves about what their values would be if they did get sicker. And one reason to do that is because it's good to be prepared, and most people want to be prepared. But the interesting research we have on these conversations is that when patients and families are able to talk about their values and goals for the care, what we find is patients actually report a better quality of life, they have better mood, and they're more likely to get the care that they want to get if they do get sicker. So there's lots of good reasons to have these conversations. Here at Mass General, we've been working on these conversations for a long time, actually a number of years before all of this happened. We adopted a program called the Serious Illness Care Program, and it comes from Atul Gawande's lab. He's a surgeon who has done a lot of process improvement work. You may have read his book, Being Mortal. And what he did is he took his surgical process improvement ideas and he kind of shifted them onto my field, onto palliative care. And he said, hey, wouldn't this all go a lot better if you guys had a checklist of questions to ask? Wouldn't it give you a little bit more structure and feel a little bit safer for everybody and kind of help clinicians stay on task? And so that's actually what his program does. And that's what I train clinicians to do, is to use a script or a guide to have conversations with you about your values and goals for the future. And one of the things we know is that, and I guess it's a problem of abundance, medical care has gotten so complicated. It's really hard to know exactly what you want. Do I want dialysis? Well, that depends. Like, what else is happening to me when I'm asked that question? And so rather than asking people hundreds of questions about what they might or might not want, what we've learned to do is understand people's values and kind of what kind of care they might want to have. And then we can match the medical plan to those values. So at Mass General, we've trained over 1,300 clinicians to have these conversations. You may have noticed people were calling patients during the pandemic to try and have some of these conversations while people were still well. Or you may ask your clinician if you could sit down and maybe think a little bit more about your values and wishes for your care. In our medical record, we also have a place now where we can write down what your priorities are. It used to be clinicians would have these conversations, but then nobody would know where to find the information, and it was really hard to use that information if someone was really sick. And now we have one place where everybody knows to look so that we can build on conversations over time. These Matters Most conversations are about values and goals. And so you'll be asked questions like, what are your worries? What are your hopes? If you got sicker, what would be most important? And how much are you willing to go through for the possibility of more time? What are your most important abilities that you couldn't imagine living without? So they're really not about making decisions. They're really about reflecting on what you want now and what you might want in the future. So you have a chance to think about it. The first step to these conversations is often picking a medical decision maker so that you can have the conversation with them so that they can also know that information. And I would say, I always tell my patients, the first step is picking the medical decision maker. The second step is talking with them about what your priorities and values are. So it's often a two-step process. It's sometimes many more steps than that. And you may have a series of conversations with your family, with your primary care doctor, with other specialty doctors, because our values change over time. And part of the process is beginning to think about them and reflect on them. So I'll just leave you with one more thing. It always feels hard. I always am like the downer in some ways, thinking about the what ifs and the scary types of things. But I would leave you with this, that the reason to do these conversations, it's not really to prepare. Of course, preparing is important. But the really important thing about thinking ahead that we find when we talk to patients and families who do it is that it actually informs how people live. It informs the choices and the way that you live in the time that you have. And that's really the reason to take a little bit of time with your family and your clinicians to think ahead. All right, everybody. I'm going to turn it over to Nori.
Thanks, Juliet. Hi, everyone. My name is Nori Mazzone, and I am a program coordinator at MGH, and I also teach a movement practice called Ageless Grace, which I will really just tell you about for about a minute. You're going to get an email that talks about the program with a little video in it. But reflecting on what Dr. Beer was saying earlier about taking care of yourself and how that it's not selfish, getting good sleep, eating good food, being outside, getting movement. That's really what my program provides. So I teach it on Zoom every Tuesday and Friday at 10:30. Class is about an hour. And we've been doing this for a while now. We've got about 20 people who come. And really, it's a way to move. It's done with music. It's done seated. It's a way to get out of social isolation and into community. It's a way to reduce the stress response and increase the relaxation response, which is what we want for feeling healthy and well. I had one of my students say to me, I've never done anything where I feel both relaxed and energized at the same time. I don't know what you just did, but I really like it. So the program is called Ageless Grace. It is based on the science of neuroplasticity, that our brain and our central nervous system has the capacity to change, that we're not stuck. So it's based on movement and play in the body with music to keep ourselves well and to reduce stress and bring in a little bit more joy and community. And there's a lot of laughter. So I invite you to come on Tuesdays and Fridays. You'll get some information in your inbox. Thanks, everybody.
Thank you, Nori. And I just want to underscore Nori's program, how wonderful it is. And sometimes we actually do a brief exercise on our town halls. And I can attest that I always feel energized. And it's really fun to do things like spell home to James Brown with your arms and your legs. And my favorite part was she made us do it with our belly buttons. That was interesting. So I encourage you, yes, I can see Dr. Beerer is testing this out. So I really encourage everyone to take a look at the brochure or just look up the program. And try to join Nori in her classes. So with that, we're going to move to the questions and answers. I'm going to go back to the elevators for a minute because there were several questions about keeping our elevator safe, how many people can be in an elevator, and how should you manage actually pushing the buttons to get to the floor you want to go to. So Maya, I don't see you, but I'm sure you're still here. So would you like to maybe address that?
Sure, I will do the best I can, and then I'm happy to follow up as well. So there's such a reduced number of people in the hospital right now, and so many regulations around who is let in, that there really has not been, anecdotally to my observation, much crowding in the elevators. I've been at the hospital since this has began, and I've rarely shared an elevator with more than one person. And people are very respectful of physical distancing, and so sort of stand at opposite ends. In terms of pressing the elevator buttons, there's no special process in place, although people are pressing them with their elbows, I've noticed, more than their hands. When people enter the hospital, they have to hand sanitize and put on a proper mask before they come in. So that's cutting down on the number of germs on any given surface in the hospital. So in terms of and then the hospital cleans the elevators routinely. In terms of actually regulating the number of people on and off, I cannot attest to that happening. I just know that most elevators at this point are not at all at full capacity because of the reduced number of people moving around the hospital.
Okay, thank you. Oh, go ahead.
No, and since that's not a completely concrete answer, I'm happy to follow up on that. I think it's a good question, and one that if one person is asking, probably several others have thought of it as well.
And Maya, I'm going to give you one other question while you're with us, and that is, if someone is legally exempt from wearing a mask under the laws of the Commonwealth, how do they actually get into the hospital if they have an appointment? And maybe Dr. LaRue, you might know that one as well, but go ahead.
You can't. I don't know. At this point, no one is allowed into the hospital without a mask. So I think at that point, you would have to pursue virtual care. There's no one in the hospital without a mask on right now. And it can't be a personal mask. It has to be a hospital issued mask.
Okay.
I mean, I think there are people, yeah, I mean, maybe there's a couple of people for medical reasons who can't wear them, and maybe there's another shield in place, but the vast majority of people need to wear masks.
Okay.
It's pretty small. Yeah.
Okay.
Dr. LaRoe, do you know something different?
No, I'm not aware of anything different, though I suspect you're right, Maya, that they at least need a face shield to cover. So there is some form of barrier.
Okay. The next question I want to go to is, Dr. Beer, can you just let us know what is the turnaround time for test results, COVID test results right now?
Well, I think for the in-house tests that we're doing, I think it's a day. And I think part of the delay is the scheduling. And if somebody, it's not an urgent issue and it's an outpatient issue, then how long it takes to get scheduled may be more than a day. My experience is that people are getting tested within 24 hours of being scheduled for a test at an outpatient facility, and we're getting the results for the MGH test in a day. We are trying to figure out which tests are more urgent than not. Any inpatient who gets tested, and at the moment all inpatients are being ruled out for COVID, I think. Correct me if I'm wrong. Those are within hours, and they need to be. The state, there are lots of tests that are done by municipal and state authorities here, and some of those are taking a long time, and those are more. They're less useful the longer you have to wait.
Okay.
Can I?
Okay, thank you.
Can I add on to that, Susan?
Sure.
That they are. Michael made mention of this, but because I work so closely with the nurses, I get a lot of feedback about it. That they definitely are triaging why a patient needs the test, and so if you're on the call and have upcoming travel and need to get the test or want to get the test for that, that's not considered high priority if it's to go visit friends up in Maine. So I would suggest getting it sooner rather than later, or at least, contacting our office sooner rather than later if it's for, a pleasure trip or vacation.
Okay, thank you. I'm going to give the next question to Michelle, and that is, how are we planning on administering flu shots this fall, and is there any thought of doing it outside, where there's more open air and whatever?
Yep, so there are many meetings ongoing right now with infection control department regarding how are we going to set up our flu clinics this year. Clearly, it's a very important year. Every year is, but I think this year takes extra precedence. We haven't received our supplement of flu vaccine. We don't get that until the end of the month, but there are ongoing discussions about different locations than ever used in order to ensure that there's social distancing. I know they're still evaluating sites for the hospital, so there's no definitive answer. But they are actively planning and looking around the hospital as to where would be the best place so that there's not a lot of, as you can envision, long lines, and they can allow enough distancing. So it will be different than previous years, but I don't think they've determined the final site.
Okay, and I'm going to send one other question your way. How are we handling mammograms right now?
So I do want to stress that as much as Maya was discussing how the management of the IMA is very vigilant, this is true for every department of the hospital. So radiology is doing routine mammograms, as well as obviously diagnostic studies and any radiologic study that is needed. Bone density, as well as, say, a CT is being performed. Blood work is occurring in our lab. It's very important if you have diabetes or your cholesterol needs to be checked, or your kidney function, do not hesitate to go to the lab. They are practicing the same vigilant infection control measures. So every department, from IMA, across the hospital, across outpatient, we're following the same measures. So don't hesitate to go for the routine care as well as the urgent care you need.
Okay, and I'm going to give you one other question, and that is when somebody is scheduled for a virtual visit, and I think this is related to when they are waiting, when they're already on the visit, is there a way to let people know if there's going to be a delay or a waiting period?
So I think that is actively being worked on. I'm not on the direct virtual care team, but this is a common concern we have heard from patients. On our end, we have a little sign that comes up that says the patient's in the virtual waiting room, and we push a button to let you into the waiting room. But as you can imagine, our visits are scheduled every 30 minutes. And particularly in primary care, it's often not for one condition, it's for multiple things or things that we weren't aware that the patient wanted to discuss, and possibly it runs over. We feel badly because we know we can't let you know what's occurring, and yet we also know this patient needs our time. So we are actively working at finding a way so that we can quickly let the patient know not to leave, that we will be there shortly.
Okay, and this is the Stump the Stars day for you. So I have one more question, and that is, do you think that there will be flu clinics set up at MGH West in Waltham and also at MGH Danvers?
I don't know about Danvers because that really is out of the MGH, it's an affiliate, but I do know at MGH West, I would say I'd feel very confident.
Okay. I think that I have addressed all the questions that came in from the chat. If anybody else has anything else they'd like to ask, now's the time to send it in. And I'm gonna, while we're seeing if we get any more questions, pneumonia shots. We have a question about pneumonia shots. So how are we dealing with that?
Yep, so that is part of routine care, and that is delivered at office visits or a nurse visit. So definitely if the person is due for their pneumonia shot, that's not given like the flu shot every year. At age 65, we give the initial vaccine and then rebooster depending upon conditions, but that could be 5 to 6 years apart or not ever again. One may be adequate depending on your health risks. So it's something delivered at the doctor's office. So nowadays, many commercial pharmacies, if you haven't received it, they can deliver it to you and your insurance covers that.
Okay, thank you. And actually, we do have another question, and I'm going to direct this to Dr. Beer, and I'm going to read it because I'm not 100% sure if I understand it, but I think I do. Could you speak to immunosuppressants? And I assume that is somebody who might be immunosuppressed, and the risk-benefit of delaying care if chronic conditions are stable.
So just my understanding of that question is, say I'm on one of the MABs, a disease-modifying drug for, say, Crohn's disease, and I'm immunosuppressed, and I'm supposed to get my routine monitoring labs or a routine type of visit with a provider. How do I balance the risk of being out there in the world or being in the hospital with potential infections versus the risk of not getting these monitoring tests? And this comes up all the time, and it's been something we've been talking with our patients about since March. And the risk is changing. The risk of, we are now at a pretty low seroprevalence in the I have to be careful. Low rate of positive tests for COVID in the community, and we have low rates, we think, of transmission in the hospital, and we're being very, very careful in the hospital. So at this point, I'm telling my patients not to delay routine care, even if they are immunocompromised. Now they might not necessarily have to come in for a full routine physical exam, but if there are critical labs to monitor, for instance, blood counts or liver function tests or kidney function, those can be done very swiftly and safely in the lab. And then coupled with a virtual visit with a provider, you can get, 99.9% of the way toward full medical care. So I think, I don't think, if that's the question, I think the time for delaying routine care if you're immunosuppressed is over. I think you should take care of yourself.
Okay. Can you just also answer, if somebody needs blood work done, how do they do that? Does it have to be scheduled as an appointment to come in just to the lab?
My understanding and what my patients have experienced is no, you don't need an appointment, but you do need to have the test ordered. Otherwise, if you don't have business in the building, we're not going to let you come in to stroll around. You're coming here for a reason. If you have a blood test, that's a good reason.
Okay. Okay. We also have a thank you from Bill Kiefer, who is one of the really active and wonderful members of the Mass General Patient Family Advisory Council. So thanks back to you, Bill, for joining us today. We have other thank yous for everything that we're doing. And I just have one last question, and then I'm going to turn it over to Dr. Leeds. And the last question is, what are some examples of symptoms? And Dr. LaRue, I'm going to give this one to you, that require a call to the PCP, and what is the best way to contact?
So I think the symptoms are very, I would say, non-specific. And by that I mean cough, fever, sore throat, body aches, things that you have had when you've had a common cold or flu can also be COVID. And then we'd want to know if you have a fever, cough, sore throat, or body aches. But other particular concerning symptoms would be shortness of breath. We'd want to know loss of smell, loss of taste. And then there are some more, I would say, unusual symptoms of COVID, such as diarrhea, or even some dermatologic or skin changes that can be shown. You've heard about the COVID toes, where it was an unusual presentation where they had almost, I would say, it looks like red marks on the ends of their toes. If you have a symptom that concerns you, I always think it's better to be safe than sorry. That's always been my motto. Rather than worry it alone, call us or Patient Gateway us. But I always tell patients, Patient Gateway is not an urgent way of getting a quick response. It will have at least typically a 24-hour, if not a bit longer, turnaround. Sometimes faster. Many physicians are faster. But if you really need a response here and now, call the doctor's office, call the PCP office.
Okay, I'm actually going to give you one last question, and that is the requirement, the legal exemption from wearing a mask applies to all workers and customers of business and other organizations open to the public that are permitted to operate as COVID-19 essential businesses. Do hospitals have a legal exemption to that law?
Not that I'm aware of, but I meet weekly with the infection control team, and I will bring that question up and forward it on to you, Susan, so you can disseminate that. I'll get the true answer from infection control.
All right, thank you. So I want to thank all of our speakers for the wonderful presentations you've given today, and I'm going to turn this back over to Dr. Leeds.
Thank you so much, Susan, and thank you to all of our speakers and to all of you. Some of the most important people in my life, both colleagues and patients, are sitting in the Zoom room with me today, and it gives me great joy, and it gives me faith in humanity that people are coming and spending their time to educate themselves and hopefully their families about the pandemic itself, and also how to continue to get the important care for other non-pandemic related illnesses during this challenging time on so many levels. So I want to thank you all for that. And I'm also just going to refresh everybody's memory that keeping yourself safe can be as simple as washing your hands, keeping your hands away from your face, physical distancing, and wearing a mask. And if I might inject a little bit of humor into this, as many of you know I do, saving the world while wearing a mask is the very definition of a superhero. So
Thank you. Thank you. And we have one last thank you very much. That was great, from one of our participants today. So we will be sending out a recording of today's presentation to everyone, along with some other documents that we think might be helpful. Please don't hesitate to share these with friends, family, anyone else that you think may benefit from the knowledge that we've shared today. So thank you so much for joining us, and I hope you have a wonderful rest of your day. Take care. Bye-bye.
Thank you.
Bye-bye.